Dr. Michael Hunt is an affiliate scientist at ARC. He's also director of Motion Analysis and Biofeedback Laboratory and assistant professor in the Department of Physical Therapy at UBC. He's going to talk to you about to exercise or not to exercise. Dr. Hunt?
Thanks very much for inviting me back this year. It's a real pleasure to be here this morning. For those of you who weren't here to see my talk last year and who don't know who I am, I'm a biomechanist, which means that I study and I analyze how people move and what effects particular movements have on the body, particularly the knee joint. I'm also a physical therapist, so I do a lot of research looking at non-pharmacological, non-surgical treatment options, exercise being one of the main ones. And what I was asked to talk about this morning was, what are some of the exercise options for people with moderate to severe osteoarthritis? And the main question is, should people with moderate to severe osteoarthritis exercise? And the answer is yes. Thanks for your time. I think it's been pretty clear this morning that exercise and increasing and maintaining physical activity is certainly advocated. So I just want to talk about three things this morning. What does the evidence tell us about exercise for moderate to severe OA? What is the best mode of exercise? And are there any specific types of exercises that are best for people with moderate to severe OA? And a lot of where this came from was kind of the traditional view. And if you look at this pyramid of treatment, what you see is as you go up, I pressed the button again. As you go up, you increase in terms of disease severity, and your treatment options become less and less. So for people who have mild disease, you're looking at exercise, you're looking at education, weight loss, self-help, simple analgesics. As you get up to the top with more severe, really your only option is surgical, total joint replacement, other types of more powerful pharmaceutical options. That's kind of the old approach. Not many people will abide by that these days. Certainly people who do have a very severe osteoarthritis, for some of them, surgical treatment is kind of their best approach. But what we're here to say this morning is don't forget about the bottom of the pyramid and some of these earlier interventions that can be utilized throughout the disease spectrum. Dr. Sévère talked this morning about the latest American College of Rheumatology guidelines that have come out, and this is kind of the current opinion that's progressed a bit from that pyramid that I just showed you. And this is a quote taken directly from those guidelines. So the technical expert panel strongly recommends that all patients, all bold, capitalized, underlined, bold, 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 all patients with symptomatic knee OA be enrolled in an exercise program commensurate with their ability to perform these activities. If you're able to perform any sort of physical activity exercise, do it. That's kind of the guidelines and the common belief these days. This was a study that was published in 2003, and what they did was they asked a number of rheumatology professionals, general practitioners, different healthcare professionals to rate the toxicity profile. And what that means is basically the safety of a number of different treatment options for people with osteoarthritis. And what they did was they said, rate it on a scale of 0 to 100, 0 being totally safe, 100 being unsafe. So obviously the lower the score, the more safe and the more advocated the particular treatment is. So what you can see is on the left-hand side here, we have kind of your drug approaches, paracetamol, which is your acetaminophen, NSAIDs, which are non-steroidal anti-inflammatory drugs, your ibuprofen-type drugs, injections, arthroscopy, joint replacement. And they all have a kind of a moderate amount of toxicity. So they're moderately unsafe, moderately safe, depending on how you look at it. On this end of the scale, we have education, exercise, and hydrotherapy, which are very, very safe, advocated by many, and generally believed to be safer options than these other approaches. So not saying that the options on the left are not great, that they're not safe, but if we look at just in terms of toxicity profile, education, exercise, and hydrotherapy are deemed to be safer. What does the evidence tell us about the effects of exercise and other sorts of non-pharmaceutical, non-surgical approaches? This is data that was taken. I did research in Australia for a couple of years, and at the time we were doing a number of clinical trials looking at the effects of exercise on pain, on physical function, and a number of other factors. And what we did was we combined all of the data. We had about 500 individuals who were enrolled in our studies undergoing a number of different exercise interventions. And what we wanted to see was there a difference depending on the severity of disease, whether someone had mild, moderate, or severe disease. And one of the questions that we asked was simply, if you had to rate your pain on a scale of 0 to 10, 0 being no pain, 10 being worst pain ever, how would you rate it right now? So we did that before they got the exercise treatment. We then brought them back after 10 or 12 weeks, or however long they exercised for, and we asked them the exact same question. And what we found was that, in general, on average, everyone improved. Everyone decreased that score. So maybe someone went from a 5 out of 10 to a 3 out of 10, which would be an improvement in that pain. More importantly, what we found was that there was no statistical difference, no difference that can be perceived through statistics and numbers between those who had mild disease, those who had moderate disease, and those who had severe disease. So regardless of where you were in terms of disease severity, on average, the effects of exercise were the same, okay? Another term that popped up recently is this term called prehabilitation. So if you think of rehabilitation being something that's done after something happens, injury, surgery, whatever it is, prehabilitation is something that's done before that happens, so before an injury or before surgery. And this is a very common term and certainly advocated for people who are going to undergo joint replacement surgery. Everyone would advocate exercising before you get the particular surgical intervention. Lower limb strengthening, range of motion are kind of your typical exercise approaches that you would take in a prehabilitation approach. And there's been a number of studies that have shown beneficial results. They improve outcomes before surgery. They improve outcomes after surgery. They decrease hospital admission time, so the time that you're maybe in the hospital after you've had your joint replacement surgery, and reduce overall healthcare utilization following surgery. So there's a number of benefits for exercising, even if you have severe disease, and even if you are going to undergo joint replacement surgery. And so this is kind of a graph that I use when I'm talking about prehabilitation. It doesn't matter whether we're talking about someone who's got arthritis or someone who's undergoing joint replacement. This is kind of the model that we think of for prehabilitation. So on the y-axis here, you can think of function. So increasing function could be strength, could be the ability to walk, could be the ability to climb stairs, whatever it may be. And as you progress to the right, we're talking about increasing time following the surgery. And if we take two people, one who basically will decrease at the same rate, because obviously if you have surgery, they're in there, they're cutting tissues, they're doing a number of things, you're going to be bedridden for a while. So you should expect some sort of decrease in your activity levels and in terms of your function. And then if we assume that the same two people increase after they maybe go out for outpatient physical therapy or whatever their exercise treatment is after the surgery, what happens? What's the difference between these two people? So I've just drawn kind of a hypothetical dotted line, and maybe this is some sort of threshold of function or threshold of strength. Maybe this is the amount of strength that you need to get out of a chair, or maybe this is the amount of strength or function that you need to climb a set of stairs. And so the theory then is if you start out at a higher level before surgery, even if you decrease at the same rate and even if you decrease or increase at the same rate as another person, you will meet that threshold time earlier than if you were less functional going into the surgery. So certainly prehabilitation is advocated for everyone who is going to undergo surgery, and the take-home message from that is these are people who have moderate, severe, very severe osteoarthritis, and we're still advocating exercise as a treatment approach. So the take-home message so far, exercise is recommended by everyone, for everyone who's got osteoarthritis. It's safe, even for people with moderate to severe OA, and it's effective, okay? So the obvious question is, which mode is best? Fortunately or unfortunately, depending on how you look at it, nothing has been shown to be superior over another form. So there's been a number of studies that have maybe compared hydrotherapy, which Dr. Lee and Dr. Sévère have talked about, and they've compared land-based strengthening or land-based aerobic activity. And there's been no difference found between the two types of exercise. So regardless of which you do, you should expect similar benefits. Which type of exercise is better? So this is what's called a meta-analysis. And I'm not going to go into the details of what a meta-analysis actually is. But basically what Dr. Lee said earlier was maybe the best level of evidence, I think it was actually maybe Dr. Trouvez, the best level of evidence is a randomized control trial, highest level of evidence. Some people would suggest that if you take a number of randomized control trials, pool them all together, you might get a better indication of what's going on. Take-home message from here is larger numbers equal better effect. And statistically, there's no difference between whether you look at simple quadricep strengthening, overall lower limb muscle strengthening, strengthening in aerobics, a walking program or walking program. They all provide similar benefits, improving pain and improving physical function. So what specific exercises are best? Easy answer is something is better than nothing. Okay, I think that's kind of been rang clear this morning. Exercises that are easy to do and enjoyable. So maybe if badminton's what you really like, that's going to be the one that's best bang for your buck because it's going to be something that you're going to do often. And exercises that are not painful. And I put an asterisk beside this because I want to make it clear that exercise does not hurt the joint. It's not causing me pain. It's not making it worse. But what I find is that if you do an exercise that's painful, you're just not going to do it anymore. And so therefore, if you're not going to do it, you're not going to receive the benefits that we know you're going to get from an exercise intervention. So general rule of thumb is a combination of strengthening, so strengthening the muscles, range of motion, so stretching, things like that, and aerobic exercises. Dr. Sévère talked about the role of muscle strengthening. Really, all I want to do is just provide some simple exercises, and I want to make it, again, clear, and I think Dr. Lee and Allison this morning made it clear that it's not a one-size-fits-all approach. It's very unique to a given individual. Go see a physical therapist, someone who's trained to deliver these exercises who can provide a good physical examination. They'll be able to tailor the exercise treatment to who you are and what you're able to do. But even simple exercises, like a squat, where you're basically kind of going down and coming back up again, strengthening the muscles. Sitting in a chair with a weight on your leg and straightening and bending, strengthening up those muscles. And strengthening the muscles of the hips as well, so maybe putting a towel between your knees and squeezing to strengthen those muscles of your hips. And a number of stretching exercises as well. And again, these will be on the ROAR website, so I won't go in detail. And the last is aerobic exercise. Walking, going for a walk, going for a swim, whatever it is to get your heart rate going, bring your weight back down. So just to summarize, exercise is a cornerstone for overall clinical management across the disease spectrum. Consistently been found to improve pain and function. No type of exercise has been found to be superior to others other than exercise is better than no exercise. And adherence, obviously, is the key to obtaining benefit. Last thing I just want to mention, I'm taking a page out of Dr. Lee's book. If anyone's interested in exercise studies, we've got a number of exercise studies going on right now. This would be the contact information for one of the students in the lab who's kind of coordinating this. And this is the website to my particular research lab at UBC if you're interested in some of the things that we're doing. Thanks very much.